All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today we are meeting in the morning because once again, as promised, we have another rock star with us. I cannot imagine how many successful doctors for COVID. So they are successful in general, but for COVID, how many successful doctors we have presented here and have heard their protocols. Dr. Darrell DeMello, his protocol and his success has been so much resonating in the world that I almost every other day get a message from someone to say, when are you going to have Dr. Darrell DeMello with us? So here we are. We have Darrell with us. I've already spoken with Darrell to say I can. He said that I can call him with the first name. So we are on the first name basis today. Darrell, welcome.
Thank you very much, Mobeen. It's an absolute delight to be with you today. Thank you.
Thank you.
Good morning to you.
Thank you. And so a very quick introduction to Darrell. So Dr. Darrell DeMello has some 30 years of experience in the medical field with tenure at Wyeth Labs, India, American Cyanamid, India, CR Bard, India, Boston Scientific, US, ScyFIX LLC, USA, and Market Access, India. He performed a variety of functions in these corporations, such as global sales, marketing, market development, business development, strategic management, and general management experiences with minimally invasive medical devices in the intervention cardiology, vascular surgery, interventions, cardiac surgery, gastro-enterology, endoscopy, and ophthalmology, class 2 and class 3 medical devices. And Darrell's bio continues. It's a glowing bio. What I wanted to also share with Cool Beans is the following, and majority of you know this. Dr. DeMello has been working for COVID, and we'll ask him that how did he start doing COVID management? But check this out. Dr. DeMello has considerable experience with COVID, and I love this. 6,000 patients he has treated so far, 24,000 family members, and provided prophylaxis to 12,000 people. So I sit here and say 400 people, 600 people, and here we have a rock star who has helped 12,000 people for prophylaxis only, 24,000 family members, and 6,000 patients. So today we would ask him, number one, how did he start? Number two, what is his protocol? And thirdly, what is his experience and any suggestions for us to move forward? So Darrell, once again, welcome. Thank you very much. Tell us a little bit about your day, a little bit about your work with COVID work.
Mobeen, thank you so much. I got involved with COVID last year in January of 2019. We'd heard about COVID from Wuhan and all the other places, but I was asked to do some presentations to some corporates. So I had to learn about COVID, and I treated it like a white space opportunity and kind of learned about it, put things together, put 2 and 2 together, came up with the plan, followed all the happenings around the world. I used to go into websites and web chat rooms in China and Italy, and of course in the US, lots of access I had, find out what was happening. And I kind of learned from things as we went along. We learned that it was a inflammatory disease, that it wasn't just pushing air into the lungs would do it good. It had inflammation caused by a virus. It had inflammation. And then when the Italian doctors, with their autopsy of 50 dead patients, came up with that story of this being a clotting disease, that sealed the whole thing. The clotting became my focus. But at the end of the day, I realized if you stop the clotting, everything else you can take care of. And I'll talk more about when we talk about protocols and practice about interstitial lung disease and clotting. But in my view and my practice, clotting is my number one target. If I can stop that clotting in its wake, I can reverse the patient. And I'll share some stories as we go along about patient examples. So I got involved with that. I started actually treating patients the first week of May last year. And initially, it's a challenge. You are new to the program. You're new to the disease. Patients are new. The fear was massive. The fear even now is massive. The paranoia about the disease is massive. However, just being stable, being compliant with patients, being patient with the patients, talking to them, explaining to them the rationale why we are doing certain things, and kind of went from there. I'd also picked up on a drug called Ivermectin at one stage, and I've used that exclusively across all those numbers of patients you talked about. Ivermectin has been the only drug to reduce or prevent the replication of the disease that I use. So I'm using my words carefully here. I know in layman terms I call it the virus killer, but I use ivermectin as my antiviral drug. And that was from the Australian study, which although it was an in vitro study, which talked about 99.8% of the virus gets killed with one dose in 24 hours, I came in with a 2-dose regimen. So with a 4-dose over 2-day regimen, and that's worked really well for me without any issues. My anti-inflammatory, I did a search of all the anti-inflammatories around. I was looking for something to what I considered the ideal. And tocilizumab, to me, would have been the ideal, because tocilizumab in COVID, if it's given within the 48 hours of the cytokine storm, you can actually get some great results with that. But I'm not in a hospital. I'm in a telemedicine outpatient clinic basis. So when you're not in a hospital, you have to look for what allied drug you can use. So I came up with a drug called colchicine, which has worked again for me in 100% of my cases. I use that as my first-line anti-inflammatory tablet, and boy, that has worked brilliantly for me. The Corona study, of course, supported it, and we all have known now what has happened. But in every patient of mine, whether it's prophylaxis or whether it is treatment or family members or treatment of patients, the first drugs that I use is colchicine, ivermectin for 2 days, and I use a drug I used to use aspirin, but I found that aspirin didn't prevent the bounce back in platelets. So over the second week, when you go from day 7 to day 10, there's a huge bounce back in platelets. Okay, so with aspirin, I was seeing, normally the platelets have a 150,000 to 450,000. I was seeing 600,000, 700,000, 550,000. So with that, I sort of went to a classmate of mine who's a well-known cardiologist in Ohio, and I asked him, I said, can you help me with this? Here's what I'm seeing. I'm thinking of using clopidogrel, which is Plavix. In the US, we call it Plavix. And he said, Darrell, that's brilliant. That's a great observation, great idea. That was from case 200 or 250 or whatever, sometime in the early cases, when I changed to clopidogrel, and I have not changed from clopidogrel ever after that. So those are some of the 3 basic drugs I use. I also use other drugs. I mean, I can use steroids, dexamethasone, when I need to use it as an adjunct or as a help with colchicine when I need to use it. I do use a lot of anti-clotting drugs like enoxaparin, Lovenox in the US. We call it Clexane here. But, it is one of the lifesavers, and most of my success with the more difficult cases or the very difficult cases are with enoxaparin, and it's been a brilliant show from then. Dr. Bain?
Got it. Thank you very much, Darrell. This is fascinating. So before I ask you, so I usually ask the folks who are actually managing, I ask them questions in a succession about various kind of patients. So before I go there, I want to ask you this. How is your success so far? So you've been managing for about a year or more now. What is your outcome? What is your result? So of course, it's not a study, but what is your own result? What gives you confidence? What shakes your confidence? How is it?
As of the end of April this year, so May 1 to end of April this year, I've done little more than 6,000 cases. Okay, 90% of them, 90% of them have been on the telephone. So either video consultation or a telephone consultation. The balance have been in person at my home clinic, where I'm sitting at the moment. That's my home clinic. People come and see me. And yeah, it's risky, but I've seen patients, and I'll share the theory about why I do certain things. And it's been a very successful home clinic also over the last 12 months. My admission rate is 35 patients out of 6,000 patients. I only have 35 admissions.
Wow.
I have about 14 deaths. And all the deaths have been diabetics. Most of my admissions, I think 95% of my admissions are, I think 31 out of 34 or 35 have been diabetics. So diabetics have been pretty big when you look at who you fail with. Most of the other people, you can actually manage them pretty well at home if you get them early. So I look to get patients either day 1 to 4, day 5 to 7. And if I do get a patient day 8, 9, and 10, I know I'm in trouble, so I'm ready for the trouble. And boy, I hit them really hard if they come to me that late. If a patient comes to me with clotting, and again, I'm focusing on clotting because I think the world needs to learn one thing. This is a clotting disease. This is a vascular disease. This is not an interstitial lung disease. And I keep getting told by doctors who sit on patients, and we'll talk about CT, HR's high resolution CT scan scores, severity scores. Here we have something called a severity score, which gives us a score from 1 to 25. Okay, and for different parts of the lung, they have different scores of it. Okay, so when something is 3, 4, or 5, it's mild, very mild. So something above 7 going up to 10 is probably mild to moderate. Something between 10 and 15 is moderate to severe. You go above 15, it's to 20, it's severe disease. And when you get to 20, 25, it's more or less the patient's going to go away. Okay, it's going to go. So when people come to me with at late stage, and some of the questions we will talk about as we go along, that treatment differs. And some of my admissions have been people who come to me with CT scan scores of 20 by 25, which means 80 odd % of the lung has been clotted off. When a doctor talks to me and says, and I get asked to do consults with doctors because to find out what's happening to a family member. And when I get told, no, this is interstitial lung disease, by giving them remdesivir, and my next question will be, what is the CT scan score now? It'll be 5, what was 5 by 20, 25 has now gone to 20 by 25. And help me understand why. Because if it's an interstitial lung disease, you shouldn't have the progression of the acceleration of clotting. So people are missing that key point that this is a clotting disease. If you fix the clotting right up front, or even sometime in between, everything else will work. And that's the approach I took from case number 1, is fixing the clotting. And, so that's where we go from. So success-wise, I've had great success with all stages. I've had some easy cases. I don't get the easy cases anymore now. I don't get the 1 to 4 cases, the 1 to 4 day cases. I get all the real tough ones. And, guy shows up, he calls me, messages me with a 14 by 25 CT scan. SpO2, oxygen saturation is fine, 96, 97. What did I do? I said, either you come to my home or I'm coming to your home. And I started him on enoxaparin, started him on Clexane, started him on everything. I mean, colchicine, the works. Today he's at 98, but I'm pretty sure in his comment the next morning was, sir, I slept very well. My lungs have not hurt. I haven't slept like this in 4 days. And that's the common comment I get when I put somebody on an enoxaparin. Either I inject them or they inject themselves, or we get a nurse to do it for them. That's something that we need to learn upfront, that in that 7, 8, 9, 10 day time frame, we need to be careful with such things. I've had doctors come to me and tell me, patients, they come to me as patients and tell me that, this is day 3 of my fever. But why is the oxygen saturation at 89? If it's day 3 of a fever, it cannot be at 89. If you're at 89 and you have a CT scan severity score of 14 or 15, you are day 9 or 10. So go back. So for me, timelines are very important. I need to understand the timeline really, really closely. I need to understand the timeline because treatment depends on your timeline. I'm very, very conservative on the upfront. I do treat, I don't let anybody go without, they get the basic drugs, which is colchicine, Ivermectin for 2 days, and I give them clopidogrel. Okay. And then as they get to 7, 8, 9, 10, especially day 8, 9, and 10, should anything else happen, I may ask for a CT scan on the day 8th or 9th and see where they stand and then go from there. Blood test wise, investigation wise, I think my clinical skills today are pretty good. and I don't need blood tests. So earlier for the first 500 cases, I used to ask for blood tests upfront. Whatever day you came to me, ask for a whole bunch of inflammatory markers. Today, I've done away with that. I now ask for blood tests if I need to in very acute cases on day 8th or 9th. But mostly my blood testing and my investigation, I spend time and spend money on the back end at the end of 1 month to understand what has been the damage that the disease has left your body with, and then fix it over the next month or two. So I'm now not only doing acute COVID, but I'm also doing post-COVID treatment to ensure that nobody goes into a long haul. Okay, in India, I think we've been very successful to prevent the long haul, the classical long haul, because we all treat with drugs here. Nobody's really left behind with just paracetamol and vitamins, or told to go home and wait till you clot off, or till your oxygen drops to, you can't get breathless and all that stuff. So for us, I think we've done a pretty good job on managing that part. Yes, there have been deaths in India, but compared to some of the other countries, our deaths are negligible, and our serious cases, we've had a lot of serious cases. I think our serious cases have been pretty nicely reversed. And remind me to talk about also post-COVID, somebody coming to me with 2 months with a CT scan of 14 by 25, and how I do that. We'll talk about that also.
I'm gonna ask you for all stages.
Right.
I'm going to ask you for all stages. So first of all, just a quick comment. My apologies for, I don't interrupt, my apologies. First of all, people have been asking some comments at where are you based, where do you practice? Is it possible if people can hear where are you based, how to reach you, how much practice internationally, locally, a little more about your practice and to reach you?
I'm based in Mumbai or Bombay. Okay, I'm based in a suburb called Kandivali, a place called Thakur Complex. It's a part of Bombay. It's a part of the middle part of Bombay. So yes, I'm based here. I do most of my work on the telephone. So pan India, I can treat anywhere in the country because drugs are available across India. The drugs I use. I have treated patients in the Middle East. I do treat patients in England, in the UK. Canada and the US, it takes time to get them the drugs. I have tried to collaborate with a few doctors who I've built up relationship with so that they can write the prescription. I can give the consult, they can write the prescription, but I can't take on the real tough cases I can do in India because we don't have the free availability of drugs in the US for various reasons. Okay, I'm not going to go into those reasons. Okay, in India we do have access to all the drugs. And it's a much simpler practice. It's a much simpler thing. At the end of the day, I'm a clinician. I'm not a scientist. I'm not a regulatory guy. And my goal, my objective is to make that patient better as fast as possible. If you have an SpO2 of 60, you have to come back to 85 at least if I'm going to work with you. And within hours. I've had a 60 at 6 a.m. in the morning, come back to 96 by 10:30 at night. So I do take on some really bad cases. If you're 66 and you get only to 81 or 82, you go to hospital. I'm not continuing treating you if you're not above 85. My cutoff level for the night is 85 on the oxygen saturation ratio. However, that changed in certain cities when we had this over the last 2 months, actually from mid-Feb, we've had this sudden surge that took all the beds out of the system in places like Greater Delhi, Chennai, Bangalore. So I've had patients that have been treated that came to me many times late night, 9 o'clock, 10 o'clock at night, 11 o'clock at night. And as long as we can get a nurse or a compounder or a doctor to treat them locally, give them what I want, and they have, if I deem they need oxygen, we can do it. I've been able to actually treat those kind of patients pretty aggressively. And it's dependent on the system, on what happens in the time. Practice-wise, I'm available. My name is pretty much out there. I do have a website, drDemelo.in. I'm on Instagram. I'm on Facebook. I'm all over the place. I have a great assistant, Astrid, who is outstanding in handling my social media commitments. And reach out to her either through the phone or through email or through whatever way you want to get to her. we will be able to help you in some way. We can help you.
Awesome.
I cannot treat you in the US for various legal reasons. I'm not registered in the US, so I don't have a registration in the US to treat you. I can advise you what to do, but I will try and work with your local doctor or somebody in the fraternity who can actually prescribe the medicines for you and all that. So US, Canada, the UK, any of the countries where medicines are tough to get, it's a nightmare for me to deal with, but I can give you the right advice and tell you what to look for. But again, that's up to you to work with your local doctor and go from there. So, yeah,
Got
Dr.
it.
Bean.
Got it. Thank you very much, Darrell. This is excellent. So, a virtual hug for you from me and all the cool beans over here.
Thank
These
you.
are sometimes people send me a comment saying that you become very childlike happy when you talk with some people, and they think, I got some comments as well, that they think it is something to do with the kind of guest I have. It's a very simple thing. A person who's serving humanity at this time, when majority of the ones responsible, CDCs, FDAs, WHOs of the world, it was their responsibility to step in and provide the care that we needed. And they are busy munching at the money and collecting more money and letting people just not have any prescriptions, any management, and just become worse and then die. So in such situation, I think we can all recognize the folks who jumped in and are saving the humanity. So these are the
Right.
kind of folks which we should be looking up to at this time. This is why I start glowing when I talk with such folks. So Darrell, thank you very much once again for your work and your help. I can realize how tough it is, because after my talks, my whole night, majority of the days, are people calling me and saying, hey, my father has gotten oxygen at 88 and my mother is in this situation, or my daughter is in this situation. So it is a tough time at this time, and thank you for your service. Now, if you give me a second, I want to go over uh, category by category to hear
Mhm.
your protocol. So if you are okay, can I start asking you your protocol once again,
Sure.
but I want to package it for people so they can listen to this part and say, here is the protocol. So let's start from
Right.
the pregnant women. So we're going to start from the beginning of life. So pregnant women, how do you manage pregnant women?
With pregnant women, you have to be careful, and depending on what stage of pregnancy they are, what trimester they're in. So trimester one, my experience, okay, the loss of the baby is pretty high. The chance of a loss of the baby is very high, extremely high. Trimester two, it's a 50-50 chance. And trimester three, usually nothing happens to the mother or the baby if you can treat correctly. And I've treated all kinds of patients, uh, trimester one, two, and three, both with normal SpO2s, and they've gone through the disease nicely with no uneventful days. And I've had, eventful days and bad days with some patients who've been trimester one, two, and three. But I work closely with the gynec. With the obstetrician, I got to work very closely to manage the child also, the fetus. So whatever I do, we always say, let's do and I work with groups. So I end up creating an online group. And from that online group, we end up working together, add whoever needs to be added, family members, husband, parents, anybody who's direct caregivers, and maybe the obstetrician is added to it. So they can also help with if something's going wrong. It's always good to have more eyes on what's happening in the case. And, especially in the home, you want to have everybody involved. So that motivation in the home becomes more encouraging for the patient to recover faster. Okay, so yes, I've treated all kinds of pregnancies. Uh, but it's a very small percentage of my practice, given the fact that 6,000 cases. I don't think I've treated more than 100 pregnant women.
Got it.
So I've treated newborn babies. I've treated newborn, newly delivered. Uh,
Neonates.
mothers who've just delivered babies. So I've
Hmm.
treated them, but I've never really. I don't have large numbers of pregnancies that I can talk about. at least 100 pregnant women I've treated in over the 6,000 cases. So
Got it.
it's been a pretty decent experience. Okay.
Got it. So if we move then to the children from pregnancy, so children, what is your experience with them and how do you manage them?
Children, the youngest child I treated was 3 days old. And the oldest child was, I'm going to put people above 10 as being adults. I treat them more like adults. But say 10-year-olds, okay, I've treated up to 10 or 12 years old, if you want to put it that way. But the 3-day-old, the 2-month-old, the 6-month-old, the 12-month-old, anybody who's breastfeeding their baby will get the treatment and will get the treatment. The child will benefit from the mother's milk. So I don't give additional medicines unless they have symptoms like fever, unless they have other symptoms that are significant of COVID. They may be COVID positive, but from the RT-PCR test, but not necessarily are they going to show major symptoms. And this goes across the pediatric spectrum from 0 to 12 years. I've not seen too many bad cases of pediatric. I did have one with red toes. And on the video call itself, I told the lady, she happened to be a person who I know very well, it was her niece. I told her, please do me a favor, take that child to the hospital, a 2-year-old young girl with absolute red toes. You go to hospital, I'm not touching you. You're safer off in the hospital. I've taken on a lot of kids with fever, 5, 6, 7, 8-year-olds. You manage the fever, you give them maybe a half a dose of Ivermectin, maybe some dose of colchicine, crush it up and give it with some syrup, and over 10 days they'll do fine. So it's not a big thing to treat these children. So the whole thing with talking about children, I'm going to make a comment here about children. There's been a lot of speculation about the third wave hitting India and hitting children hard. I personally think no. The children are to me like green forests or green sticks. You can't burn them down. So I don't think that, again, given the experience I've had, I don't think children will get affected in the third wave. And I'm putting it out in public. We'll see what happens in the third wave, but I don't think children get affected. Anybody above the age of 12 or 15, I treat them like full adults. It's far safer than to allow them to get into problems. Okay.
Got it. So let's then move to the adults. So adults, your definition, 12 years and onwards. How do you treat them? And again, what I'm trying to do is I'm trying to get your protocol in a one concise segment of this video so people can hear that part. So for the adults who are in the early part of the disease, so let's say day 1 to 4, as you mentioned, what is your usual regime if there are no comorbidities?
For generally, if again, when I can talk about 12 to 18 and then 18 to 30 and go on with that. But in general, for day 1 to 4, the basic drugs they'll get is colchicine. And, for an adult who's 18 plus, he gets 1 milligrams in the morning and he gets, half a milligram at night. He or she will get that. That's colchicine. It's a straight 30-day treatment. I don't do 5 days, 7 days, 10 days. I do straight 30 days. And then we'll reevaluate the drug usage after that at the end of 30 days, after doing the inflammatory marker test. I do give a dose of ivermectin for an adult. So in my case, I do the two doses a day. So I do a 7 a.m. and a 5 p.m. on an empty stomach. It could be 5 a.m. also, depending on when the patient gets up. But I do it on an empty stomach, and I have a rationale for why I do it on an empty stomach. I do morning and evening 2 days, and I'm done with the ivermectin part.
And what
I haven't still had a patient. Yeah.
Sorry, my apologies. I just wanted to ask, what is the dose of ivermectin? How much milligram per kilogram do you administer?
Okay. Let me talk about how I give it to them. I give it to them on an empty stomach with nothing to eat or drink for 2 hours after that. And the rationale for that is this drug, ivermectin, was developed as an anti-helminth drug, okay, which was needed in the gut. You needed high levels of thing in the gut. We need for ivermectin, we need it in the lungs, in the throat, in the nose, in the blood. To get it up to that level, I know there's some data which says, what I'm saying is wrong, but I have had great success with ivermectin with a 4-dose over 2 days system, in a way that on 24 hours after their last dose, I allow the patient to come out and mix with the family. They need not remain in room isolation. And I've done it across all 6,000 patients. I have no changes to that. The good news is that I haven't had anybody be infective from day 1 to day 4 to anybody else in the family. So it's just, again, you judge your success also by what happens to the other members of the family. So the ivermectin dose seems to work very well, but also I'm allowing the patient to come out and mix with the family and rejoin the family, 24 hours after their last dose. So it really makes no difference to me.
Wow, that is beautiful. Do you use 0.2 milligram per kilogram or 0.3 or 0.4? What is your basic?
I use a standard 12 milligram dose for adults. So it's straight 12 milligrams in the morning, day 1, in the evening at 5 p.m. day 2 on day 1. Same thing on day 2, 5 or 6 to 7 a.m. And then again, so I use about 48 milligrams over 2 days. And I think that gets me the best results I can.
Got it. So now I know that I had interjected and I broke your train of thought. You were talking about colchicine and then ivermectin. So I think we just lost Darrell. Hopefully he would join me back in a few minutes. I'm so excited for speaking with him. So meanwhile, I'm going to look at some of your comments here. I saw Nick's comment, Dr. Nick's comment about plant-based medicine or management. Let's see if I can. Nick, that comment must have scrolled past me. So is it me who is disconnected or is it Dr. DeMello? So can you hear me? Can you hear and see me? Okay, so I am here. I can see actually Dr. DeMello back.
Outage.
Yes, no worries. Thank
Hello.
You very much for being back. So I was apologizing that I had interrupted your train of thought. You were talking about the first 4 days, colchicine, ivermectin, and I wanted to dig in a little more about ivermectin. So please, if you can continue, my apologies. Colchicine, ivermectin, then what else? Vitamins, other things?
I actually don't use vitamins. Okay, I use clopidogrel in adults, and in young adults, if I use clopidogrel, it'll be somebody who I'm expecting to clot off. But usually above 18 standard, they'll get one tablet, which is 75 milligrams of Plavix or clopidogrel for 15 days or 30 days, depending on what day, what severity, and all that stuff. So it's kind of the way I work with my combination that I use. I use a combination of drugs. It's not a single drug therapy. It's a combination. I try to attack all 3 fronts. The virus, so you reduce the replication of the virus, so you prevent the replication of the virus, allowing the body to do the rest, which is kill the original virus. The second thing is reduce the inflammation of the body by using colchicine. Okay, and colchicine is a fantastic, I call it my fire retardant. It's a fantastic fire retardant, and I can, explain to you why and all that stuff, but I think we'll just stay away from that for now. But it's a fantastic anti-inflammatory agent. And if you can prevent the clotting up front, and in some adults, some high-risk adults, like diabetics, or somebody with heart disease, or somebody with anything that could make them high risk, or obesity, okay, I will do the 4-dose, 4-drug, so 4 tablets start the first day, and then 1 tablet a day after that. So I do a little bit of changes, and those changes have come in, over the year. I've made little minor changes, minor tweaks to the whole protocol, but the basic protocol remains the same.
Got it. Thank you very much for this one. So before moving to the next category, I want to put a question out. So Nick Ariza is actually a physician. He is from Canada. He has a question. Does Dr. DeMello ever prescribe a whole plant-based diet to help manage reverse type 2 diabetes? Great interview. So this is a slight departure. I want to come back to COVID, but if you would like to comment on this message.
I'm going to talk about the diet I prescribe in COVID. It is a soft food diet. So I use the dal and rice. Okay, dal is legumes, so I use the dal and rice cooked, really overcooked. I recommend a lot of soups, and yellow pumpkin soup is probably one of the best things for people to have. All kinds of soups are acceptable. I also give, a lot of yogurt, a lot of curd, a lot of dahi. I give a lot of dahi to patients. I recommend them to have that, besides having a lot of fluids. So, lime juice, juices, soups, anything, but nothing that can hurt their intestinal function because of the inflammation. Of what I've seen in COVID is the inflammation affects the whole nervous system, and the brain tends to lose control of the gut. So you get vomiting, you get nausea and vomiting, you get diarrhea. So I've seen patients with colicky pain, and the only explanation I can have is that there's some nerve endings or groups of neurons that are exposed and that are misfiring and causing colicky pain. And so again, you're treating symptoms. If you got the baseline treatment correct, which is antiviral, anti-inflammatory, and you got the anti-clotting, all these symptoms are easy to treat. Whether you have a cold, you have a running nose, you have a sore throat, you have diarrhea, you have nausea, it's relatively easy to treat. The challenge becomes when you get a patient who has skin manifestation of COVID. And I've had a few. They're not large quantities. They're probably less than 2% of the number of cases I've done, but I've seen quite a number of skin manifestation. And so again, those you lead with steroids. I lead straight away with, besides the basic drugs, I lead with dexamethasone. So my lead drug for that is a 5-day dexamethasone therapy, and then a taper down over the next 5 days. So it's, again, depending on the symptom you see, I moderate my drug usage. My diet is very plant-based. There's no meats. The only thing I allow a patient to have is eggs if they want to have eggs, but absolutely no meat. I find meats being very difficult to manage and process in the gut when somebody's in COVID.
Got it. That's fascinating. Thank you very much. So if we then move from the COVID, no comorbidities, early 4 days, if we move towards the next 3-4 days, so let's say up to 7 or 6 days, because 7, 8, 9, 10 are going to become more scary. So let's say after 4, before 7, 8, let's say a patient arrives at your clinic and they have those symptoms. They have not taken anything, if they're in the US at least. How would you manage them? And if they have comorbidities, most of the folks they come with the comorbidities. What is your approach at that time?
4 to 7. And I include 7 as being part of it. Okay, it's really the later part of 7, which would be part and parcel of the 8, 9, 10 story. So when they come to me day 4 to 7, 4 or 5 you can manage, 6 even you can manage. They get the same medicine the same medication that day 1 to 4 get, and they get a lot more. I get a lot more careful. I want them to monitor their oxygen saturation ratios, the temperature, and the pulse rates at least 4 times, 5 times a day. Normally, I just say, give it to me 3 times a day is good enough. So 8 a.m., 2 p.m., and 10 p.m. at night is fine. But you get closer to day 8, and day 8, 9, and 10, I even do it a lot more. I mean, I even sometimes may ask every 2 hours, every 3 hours, give me a recording of what's happening to you. Because the one hard data point that I depend upon, besides the patient's symptoms and besides the patient's comments, is the SpO2 reading. And so that SpO2 reading, that oxygen saturation reading, becomes very, very important from a treatment perspective. And I have clear-cut guidelines. Anything below 95, they're going to start on enoxaparin, all the way down to 85. If they fall below 85 in the night, Ideally, they go to hospital. If I can't get them a bed, I'll try and manage them at home. But ideally, they go to hospital. If they come to me with 80, 85 in the daytime, even 75 in the daytime, and even 60 in the daytime, if I can get them up to 85, 90, then I'll keep them at home and treat them. But again, it all depends on an individual patient.
Got it. So then if we go from now the more dangerous times, 7 days onwards, advanced age or comorbidities or just generally deteriorating, how do you approach that?
Right. Here's where I'm going to differentiate between the old virus and the variants. Okay, the old virus, up to day 7 was really not a problem. Day 8, 9, and 10, you could expect certain things. What I'm seeing in day 8, 9, and 10 nowadays, people who come to me late, who come to me day 8 particularly, I'm seeing accelerated clotting. I'm seeing very high severity scores in the CT scan report in the lungs. And if I see something above 10, I know I'm going to expect them to go to 20 in 3 days. If somebody comes to me on day 7 or 8 with a CT scan severity score of 10, 9, 10, 11, 12, they will plot off to 20 in the next 48 hours. So that's what's happening here in India. And that's what's happening with and I don't know whether it's a variant or is the drug usage that's happening. We do have a lot of usage of 2 drugs called methylprednisolone and favipiravir. And I'm unable to fathom as to, is it the drugs or is it the variant or is it a combination of what's happening? I mean, so again, it's just an observation I'm making that I see a lot more accelerated clotting now than what I saw before. Before, I don't think I ever saw a 15. Now 15 is standard. 10 and 12 and 15 is standard. People just show up with 14 and 15s. Now, is it because I'm getting tougher cases because of the fact that I've graduated up the stream, or is it because there's an accelerated clotting? I don't have that answer for you. But that's so day 8, 9, and 10 are tough days. And here's what I make them do. Sometimes when let's say a patient comes to me, or they talk to me, or I'm asked to see somebody at home, and their SpO2, the oxygen saturation ratio, is 85. When it's at 85, okay, I give them enoxaparin. I may give them a shot of dexamethasone. I may do a whole bunch of things, give them colchicine and clopidogrel or whatever I need to give them, I give them. More importantly, I make them mobile. I make them walk, sometimes the whole night. Night of the 8th, night of the 9th, you're going to walk, you're going to prone, you're going to exercise. I've told people, you want to live tonight, you're not going to sleep. You need to go from 85 to 93 by tomorrow morning. Otherwise, you're in trouble. And most patients have succeeded. So it's not a difficult thing to do. You teach them how to prone. You teach them how to walk, and you tell them to monitor it. And many times, sometimes when you may find a stubborn patient who may be reluctant to listen to you, you get them to hire a nurse and instruct the nurse to keep them awake. And with the nursing help now, then I can give intramuscular drugs, intravenous fluids if I need. So there are a lot of other things that come in if I can use the nursing help, if I can get that. So again, it's all dependent. Proning is one of the key things in 8, 9, and 10. Walking. Walk, and walk. I tell people, walk. Today, it's not about the 6-minute walk. 6-minute walk was good. Now it's about just continue walking as much as you can. Keep yourself mobile. When you lie down on the bed, I want you lying on your stomach, okay, in the daytime. At night, I don't mind you lying at night, but I want you to put alarms every 3 hours to wake up and walk. If you go to bed at 12, you get up at 3, you walk for an hour, do proning, and then go back to sleep at 4, get up at 7, again do it. So it's about the mobility of the patient. If you can do the mobility correctly, that clotting gets broken up. The air at the back of the lungs get aired up, get exposed. It starts breathing. So that clotting doesn't happen. So this is, again, something you pick up in practice and you enforce it, and it happens. Okay. I do use other things. I use things like injection vitamin D. I use a 600,000 injection, intramuscular injection in the acute phase. So day 7, 8, 9, 10, I may give an injection of vitamin D. I may give an injection of iron. that seems to turn around the patient many times. Sometimes you get a V-shaped recovery. Now, it's a combination of enoxaparin, vitamin D, iron, the whole bone marrow thing changeover. So there are a lot of things I've been successful with, where I've kind of innovated, and it's worked for me, it works for my patients. So today it's becoming more standard to use this on a one-off basis, an injection vitamin D. Here we have vitamin D injection freely available, okay? Iron injection are freely available, okay? So that's the acute time. Somebody asked a question about, do I use vitamin? The only vitamin I will ever recommend in COVID is actually one vitamin called vitamin D. And I don't care whether you take it as an oral or take it as an injection. In the early phases, in the early, say, day 1 to 4, you can. I tell people, take it daily. Take a 60,000 units daily for 10 days. Get away from that 10-day thing, then go from there. And that seems to help patients along the way. So I know I'm rambling on here.
I love it. This is so fascinating. So I wanted to comment on your discussion here with the cool beans. Cool beans, you are seeing three kind of approaches from doctors. One are those who are looking at pathologies and mechanisms and then thinking how to work on it. Then there are another set of folks who are just chasing RCTs, random control trials and studies to see what would they tell, or what are the protocols and algorithms would tell from CDCs and others. And then you see a third group who is clinically, they are doctoring in Dr. Pierre Corey's words. They are doctoring. They have learned how to be a doctor, and now they are being doctors. They are experimenting, they are thinking, they are figuring it out, and they are managing. So here we are seeing a doctor. I'm sure that if I ask Dr. DeMello that which studies are you following to do this, he would say, so let me actually ask that question. So Darrell, what studies have told you to do this?
The basic studies that I followed was that Australian study, the Italian study on the autopsies. The rest of it has been, I made my own protocols. I made my own drug usage. I designed my drug plans and I went with it. I'm a clinician. I'm not a scientist. I treat patients. My goal, my objective is to get a patient better,
So bingo. So see, cool beans, this is what is the answer. From a doctor, this is what should be the answer. Then those studies and those extra mechanisms and everything should help further augment their activity, their work. But this is the answer. So once again, hugs to you. The more I'm hearing you, the more I want to just be with you and sit down and just chat forever. I want to go to the next step and talk about what happens after COVID. Before that, I want to ask one question as well. We have William Goff. He is a cool bean, plus he is a healthcare professional as well. His question is, the only thing I worry about, it is the Plavix. I know it is commonly prescribed for patients with coronary issues, but is Plavix a high-risk drug for a person to take risk of hemorrhage?
Plavix is actually a safe drug. It's an extremely safe drug. I've been in angioplasty for a major part of my life, having introduced angioplasty to India, and many of the procedures like stenting and rotablator and rotational atherectomy and intravascular ultrasound, I've introduced to many parts of the world, including the US. So I'm very familiar with the drugs used in angioplasty. So Plavix is a drug I'm very familiar with. I know exactly what happens. Now, let me explain to you what's happening in COVID. In COVID, when clotting starts, it's like a leak. Once that cascade has started, you're going to have clotting coming at you so fast that you have no time to worry about bleeding. My first objective is to stop the clotting. I get this question about enoxaparin. I have given, and I'll share this case later in the program, I've given 4 doses of 60 milligrams enoxaparin over 24 hours to a patient who came to me with a 23 by 25 CT scan severity score. But the end of the day, that patient had recovered to 16 by 25, went home. 4 days later, the oximeter reading was up to 99. So that's the clinician in me. Okay. Now at 23 by 25, I could have admitted her. I tried to admit her. The hospital refused her. We got her a bed later in the day. okay, at another hospital. I asked for a CT scan. By then, I'd given her 3 doses of enoxaparin. I know what can happen if she bled. And her husband was told, if she goes into hospital, her chance of death is almost 100%. The chance of survival is like 0.01%, okay, at 23 by 25. I can stratify for you 20, 21, 22, 23, 24 by 25 being totally death scenario. I've had a young lady, 35-year-old lady, sit with me right behind me on the couch here. I had my arm around her. I said, sweetheart, I'll take care of you. Don't worry. Her score came at 20. I made the mistake of admitting her to a hospital. She was dead a day and a half later. So, guys, this is clotting. You stop the clotting. Worry about bleeding later, okay? If you don't stop the clotting, the patient's dead. If you stop the clotting, then we can adjust the dosage to make it lower. I hope that answers good enough for William Goff.
Absolutely. I think this is excellent. Thank you very much. And William, I hope that helps. Dr. Amir Hashmi. So again, I want to go to COVID in a second, but there are some important questions. Dr. Amir Hashmi, he's a physician as well. Sir, role of prednisolone in early COVID-19 to prevent lungs fibrosis.
I actually don't use this drug. My experience has been this drug doesn't help. What I use in post-COVID, and we can talk about 30 days post-COVID. I wait for the 30 days to be over and then do a CT scan to estimate what is the lung damage still prevalent. If the lung clotting is still, let's say 10 by 25, 12 by 25, 15 by 25, I go in with, again, a course of enoxaparin, okay, 1 a day for 10 days, 15 days, or 21 days, okay, and I give a drug called colchicine at the same dosage that I give it upfront from day 1. So understand that the combination of these two cleans up the lungs. I've had a 15 by 25 down to 0 in 30 days. And I've routinely cleaned up lungs from 18, 17 by 25, 18 by 25, 15 by 25 to 0 in 2 months or 3 months at the most. So guys, this is not rocket science. This is clinical science. Let's treat the patient. Let's prevent that fibrosis. Let's clean up the lungs of the clots. Talking about a lung fibrosis drug, when you have clots there, the lungs are not going to clean up if you don't clean up the clots. The earlier you clean up the clots, the better it is. Usually I see if you do it in the second month, which means first month is the first 30 days, do it in that 30 to 45 days or 30 to 60 days, you'll have no long-term lung issues.
Got it. Thank you very, very much. I want to read this comment from Mitra, and then we continue towards long COVID. So excellent program, Dr. Bean. I agree with the methodology of Dr. DeMello. While Rome is burning, WHO is standing firm on analysis paralysis. And this is happening a lot. My own friends, my own colleagues, sometimes are just saying, there is no study for this, there's no study for that, and they are just stuck. Darrell, if we can continue to the long COVID or post-COVID. We had Professor Dr. Hector Carvalho from Argentina, and he said, look, after COVID, there are 2 types of problems. One of the problems because of the tissue damage during COVID, and one is the problem where the COVID itself is just continuing, and that has become long haul. And he said management for those are different. How do you see after COVID patients and to manage them?
I see the first one, and again, and that's why my whole investigation techniques changed from doing it upfront to doing it at between day 30th and day 35th or 36th, from the first day of symptoms. Okay, I want to understand what is the damage left behind by the tsunami, the cytokine storm. Okay, so that gives me a perspective of the liver damage, the heart damage, the kidney damage, the tissue damage that may be there. I don't think, and I've not seen long COVID continue if you treat it correctly upfront. Okay, if you treat it correctly upfront, and I do treat the first 14 days very aggressively. Colchicine and Plavix continue for the balance 16 days for the first 30 days. And I may continue on colchicine for the next 30 days again. So right up to 60, 90 days. The longest I've had a patient on colchicine is 6 months. But he's had no tissue damage, no lung damage, no nothing, no brain issues for the whole, for the post period. Most often patients are fully normal, at least in my practice, at the end of 3 months. Okay, so the first month you'll have a certain group of patients who will be doing well. All their markers look great. Okay, so all I have to do is take one tablet of colchicine a day for the next 30 days. You're fine, and then you're done. But the second group, which have, say, tissue damage, which have CRP being high or LDH being high, still continuing to be high, which may or may not have CKMB high. Again, colchicine is a fantastic drug for those patients. I picked colchicine for various reasons. One of the reasons is the fact that it's a damn good drug for myocarditis. Okay, it's a good drug for myocarditis. So it helps prevent myocarditis. So again, let us use drugs that upfront that make sense, and we're able to prevent those long-term issues. The long-term issues after day 30th is more about cleaning up what's left behind, and it's not about treating the basic disease. By allowing COVID to fester, okay, if you don't see, it's not the virus that kills the patient, it's the body that kills the patient. It's the super overdrive of the immune response system, which hits the cytokine storm, which sets up clotting, which has all the other things that hit the thing. So for me, it's not about the virus. It's about the body and the body's immune response. How do we prevent that? How do we reduce that? How do we treat that? And then how do we treat the consequences of that? If I'm already treating the consequences of that upfront, there's very little left over. So I don't think we're going to have much long-term COVID, at least beyond 6 months in India. In my practice, I haven't had too many people beyond 3 months. 98% of them have recovered fully in 3 months. I do have a few who come back to me at 4 months or 5 months saying, I'm getting some headaches, I'm getting some body pain. Is this COVID? Is this not COVID? Usually that goes away if you put them back on colchicine. Again, it's about treating the underlying inflammatory problem they have.
Excellent. Thank you, Darrell. And I wanted to piggyback on this one for Cool Beans here. Cool Beans, my number of patients that I've managed are smaller than the 6,000 with Darrell. But even my own experience, you have been with me for about a year now. One patient who became long hauler after recovering and within 1 week. One patient who was the cancer patient, 2.5 months. And then a patient which I just discovered a month ago, about a year later. But a common thing that you're seeing with Darrell and with me, and I think with many other doctors who are aggressive in the beginning, if you are managing patients aggressively early, you are actually prophylaxing them from becoming long COVID, from having those sequelae, as Dr. Hector Carvalho say, and end up in a bad state. When I receive patients of long COVID, I feel that some doctor mismanaged them, not intentionally, but maybe unknowingly, maybe not enough information, they mismanaged them. If the management is done early and aggressively, long COVIDs don't happen. That's what we are seeing with Darrell as well. Darrell, your talk, I believe if we can remove all the talks from Dr. Bean and just leave this one talk here, it would continue to serve humanity for a very long time. So thank you
sir.
Thank you for this. Tell me this, patients with diabetes, you said that they are the most common that ended up in hospitals or dying. How do you then, have you adjusted, have you changed, have you, the results have improved, or that is still a bad state?
Actually, the results improved right from the first few diabetics I treated. My first patient was a diabetic who died. She came to me with an oxygen saturation of 35. Okay, 35. I told that sort of patient is not going to live. She had a blood sugar of 520 when she came to me. We controlled it, but I didn't actively control it, and I ended up admitting her 3 days later, and she ended up passing away 2 days after that. So, she was pretty bad when she came. So that's one of my first patients with diabetes. I learned a lesson with diabetes. I treat a diabetic at day 4 like I would treat a normal person at day 7. So day 4 for a diabetic is equal to day 7 for me. I get very aggressive with them upfront. I want to monitor their sugars 6 times a day. So before breakfast, 2 hours after breakfast, before lunch, 2 hours after lunch, and before dinner, 2 hours after dinner. and moderate their or titrate their anti-diabetic drugs, orals or insulin, to actually do it. As I got busier, as I got up to 60 cases a day and 70 cases a day, which is crazy, I ended up bringing requesting another colleague of mine to join me and treat these patients, just the diabetic part of it. So I do work in partnership with another gentleman, and he's of great help in managing the diabetes. And it's been he can manage the sugars, I can manage the COVID, and we're watching sugar and we're watching the oxygen saturation ratio. So together, today a diabetic should not die. If you can manage that sugar, I have targets. I want to see fasting at 70, 80, 90, 100 at the most. I want to see postprandial, that means post-breakfast, post-lunch, post-dinner, between 120 and 140. If it's not that, we are getting in trouble. If we allow it to go up to 200 postprandial, we are in trouble. We allow the fasting to get to 150, we're in trouble. So I really want it at that level. So I set those levels up front, and I'm able to manage that. So I manage not only the timeline, so I treat a diabetic at day 4 as being equal to a normal person at day 7. Then you are treating them more actively. But I also manage the sugars on a meal by meal basis. Make sense, Dr. Bean?
So so while you're talking about these things, I am continuously thinking, here is a clinician speaking. You're speaking so fluently about various cases. You're speaking so thoughtfully about how you managed and how you changed and how you learned. And I was thinking, believe me, while you were speaking, I was thinking protocols, algorithms, the rules and regulations in our Western countries have made our doctors unaware of how clinical practice happens, how a doctor learns how to manage. I used to say in Pakistan and India, doctors have to find out how to manage their patients. They don't have a choice. And so here they are, they're finding out how to manage their patients, and they're adjusting and they're managing patients. So thank you very much once again. I just keep thanking you in my heart and now verbally as well. I want to ask you the next. So if you're ready, a few questions from the Cool Beans here as well.
So let's take it, yeah.
Thank you. So I'm going to start from Dr. Ariza. What are Dr. DeMello's thoughts about dysbiosis as an underlying predisposing factor in the immune dysregulation in those who become severe COVID? So gut bio.
Nick, I don't know what. Yeah, I'm not sure about the question, and I can't give you an answer because I haven't seen such a patient in the practice I have. So my apology. I don't think I have an answer for you.
Kelly says, is there a natural source of colchicine type compound one can use if they cannot afford it?
Colchicine is a very cheap drug. It's probably one of the cheapest drugs you can get. It costs about, what do I put it, 34 rupees for a strip of 10 tablets,
Oh, wow.
0.5. So 34 rupees is about 50 cents. So you're looking at 5 cents a tablet. And it is a simple drug to use. It's got its benefits. It's got tremendous benefits in COVID in particular. So, and at the dosages we use, 1 milligram in the morning and 0.5 milligram at night, it's a no-brainer if I use the word as an anti-inflammatory. Okay, it's one of the best anti-inflammatories you can possibly use. And I gave you the rationale up front why I chose colchicine. I was looking for a drug that would match tocilizumab. I wanted the interleukin-6, interleukin-1A, interleukin-1A targeted attack. Colchicine gave me that. Steroids, which are dexamethasone, methylprednisolone, are generalized immune suppressants. I call it carpet bombing. Okay, I wanted the sniper attacks, and with colchicine, I got the sniper attack without the carpet bombing. I can always come back and use dexamethasone later if I need help. But if the sniper can't do the work alone, then you bring in the carpet bombing guy. Okay, so that's the way I work. Okay, I'm a clinician, so that's the way I am.
I love it. I love it. So, and I think Cool Beans, our community is about 1 million now. And I think they can figure out when they hear a doctor who is speaking from a clinical experience point of view. Arpan Agarwal, Thanks, Dr. Bean, for inviting a great doctor like you, like Dr. DeMello here. Role of mefenic acid in COVID management.
I can't speak about other people. I don't use it in my practice. So I'm going to be very straight. I'll give answers to what I do in practice. I can't talk about other people. Okay. I don't use it in practice.
Perfect. Sumit Kesare, he is also a physician in India. What is the exact dose of colchicine? Is it 1.5 milligram stat and then 0.5 milligram after 6 hours? Therefore, thereafter 0.5. So what is your colchicine protocol?
Sumit, my colchicine protocol is pretty simple. It is 1 milligram in the morning and 0.5 milligram at night. I've tried everything. I've tried 1 milligram 3 times a day. I've tried 0.5 milligram once a day. I've tried everything in the first few cases. What I found that gave me the best results was to do the 2 tablets of 0.5. We get the 0.5 in India. So 2 tablets of 0.5 in the morning after breakfast and 1 tablet of 0.5 after dinner. It works like magic. So guys, that's the dosage. It works for me. It has worked for me very well. And I'm hoping and praying it continues to work the way, even with all the variants, it continues to work the way it has worked. The underlying premise is very simple. It's one of the better or one of the best anti-inflammatories you can get with targeted approaches, not the carpet bombing approach that steroids do.
Got it. Thank you. Dr. Amir Hashmi, Dr. DeMello, using fluvoxamine or cyproheptadine? Or neither?
I don't use either. Okay. I've considered using fluvoxamine for somebody with brain issues, brain fog and focusing issues and all in month 3, but he did very, very well with colchicine and dexamethasone. In 4 days, his brain fog went away just with the combination of these two. And in 1 month, the guy he went back to his old self. So again, it depends on you got to make that judgment call. Am I going to add fluvoxamine to him or not? I haven't had to use fluvoxamine because I use 2 drugs in combination, which is colchicine and dexamethasone in post-COVID if they have brain issues. Both seem to work very, very well. So I have not had the need to use it.
Got it. Thank you. So I was looking here on the Twitter side. There's a question for you on Twitter. What is Dr. DeMello's current thinking about using colchicine in his COVID-19 treatment? You're just talking about it. I want to add part of his question. Do you still use colchicine day 1 of symptoms to day 180? Maybe 18 is what they wanted to write. And then what is the dosage? So do you start it on day 1?
On day 1, I start the dosage of 1 milligram in the morning and 0.5 milligram at night. So we're talking about 2 tablets and 1 tablet from day 1 to 30, depending on the outcome of the inflammatory marker test between day 30 and 35. I will then decide whether I continue the same dosage or taper it down. I may taper it down to 0.5 milligram in the morning and 0.5 milligram at night for the next 30 days, and the third 30 days, which is 61 to 90, I may go to just 1 tablet of 0.5 milligrams for the day and close it at 90 days. It again depends on the patient's clinical situation. There's no fixed protocol. I have a general protocol in place, and I think it's on lots of websites in the US today, my regular protocol. The issue I have is you've got to tailor that protocol to every individual patient. There's no fixed thing. There's no saying that you're going to get this or you're going to get that. You got to treat the patient as they are.
Makes sense. One more question from Twitter, and I hope this is okay. I know it is getting late in India. It is night.
No problem, sir.
Thank you. Thank you very much. Appreciate it. And thank you from all cool beans here as well. Vitamin D. So the question is, vitamin D at around 950 nanogram per milliliter is suggested as safer in the long term. Do you still suggest levels of 60 to 100 at all times? Vitamin D levels.
I suggest 60 to 100 in the COVID times. If you are above 60 and less than 100, trust me on one thing. Your attack of COVID is going to be like mine. Asymptomatic. I never knew I had COVID. Again, I'll talk about my story. and I do this with patients. I do it with every patient that I have. Anybody want prophylaxis, vitamin D is my number one for prophylaxis. Okay. I saw my antibodies go from 0.06 in May, 0.16, 0.28, 0.38, 0.58, 0.78. And finally, I crossed the border of 1 when it went to 1.16 the day after Christmas. That gave me the antibody positive result. Today, my antibodies, the last one I checked was 2 weeks ago, it was at 10.8. So I've continued to expose myself to patients without, I wear a mask, but beyond a mask, I don't wear gloves, I don't wear a PPE kit. I do wash my hands. I do maintain a 3 to 4 feet distance between patients. But many times when you're dealing with a patient who's maybe day 8th or 9th and they're clotting, you're not sure, is this patient virus-free, live virus-free? They may have dead virus. Are they live virus-free or not? I take the risk. If I have to go in and treat a patient sometimes, I have to go to somebody's house, and but again, I've seen my antibodies go up over time, and I can put it down to just one thing is two things actually. One thing is vitamin D. My vitamin Ds are in the 90s. At any given time when I test it, it has to be in the 90s. Otherwise, I know I'm in trouble. The second thing, I do take a colchicine tablet every day, and I take that pretty regularly, Monday to Friday. I don't take ivermectin. I know a lot of people say take ivermectin as a prophylaxis. I'm not of the camp that says you got to take ivermectin every week. If somebody is traveling and is going to be exposed, I will prescribe it as a prophylaxis. I do take ivermectin when I feel I've been overexposed. If I've been overexposed, I've seen too many patients for the day, 5, 6, 7, 8, 9, 10 patients acute right in my face. I will take an ivermectin late that night or early morning the next day to clean out whatever virus is there. So far, that's worked for me. I've probably done about 8 or 9 ivermectin tablets the whole year between May 1 last year and now.
Wow. So hearing clinicians, so this was always my fascination. Even when I was studying and I used to go to wards and I would listen to our professors and they would talk about medicine, I used to get fascinated with the thinking and the way they would reach. So today I'm getting that experience of hearing a clinician and their thoughts. One more question. Gorilla says, what will DeMello recommend for long haulers months in, being sick with shortness of breath, fatigue, and muscle pains?
I'm going to make some recommendations. I have not treated beyond 1 year. I have treated some people up to 1 year, and they're not from India. If I'm outside, I've had success. I've had some good success with some patients. Mostly, I've given them colchicine plus clopidogrel for some time and dexamethasone for some time. So again, it's a combination therapy. Colchicine could be standard 3 months therapy or 4 months therapy, but many of them have improved 50%. Now you come to me with a lung function test showing 50% fibrosis at 1 year. I'll tell you one thing: it's not possible to clean up that lung. Okay, you come to me at 2 months or 3 months with a CT scan severity score of even 15 by 25. I'll clean it up. But
how would you
beyond
do
that, I'd use colchicine.
Excellent. I think we lost Darrell again. I'm trying to see if we can reconnect to Darrell. So while we are waiting for Darrell to come back and reconnect, I was feeling so proud when we were talking with him. Vitamin D, from the very early time, cool beans, we have all heard about the importance of vitamin D and various studies, and we kept using vitamin D. So I am just so happy that we worked with vitamin D. We tried to understand the other supplements. We started using ivermectin wherever we could at the right times. So unplanned was all of this. It was not that I had a plan before the pandemic to say, I'm going to go in and do the following things. It just happened, and we all lucked out together. Sorry, Darrell, we missed you.
I'm back with you. We had a network outage, I think, again.
No worries. Welcome back. So we were talking about the vitamin D, and you were talking about the colchicine and vitamin D for your own self and prophylaxis. And so now you have your antibodies there as well. So you have asymptomatically handled the virus.
Right. Correct. And I've had a lot of people who I put on prophylaxis. I work with corporates. A lot of the corporate entities in India work with me on protecting many of their staff and protecting some of their data centers and all. So for me, it's about, you can't shut down certain companies, you can't shut down certain things, and you have to keep them open. How do you keep that open? You treat them, you give them the vitamin D, which is really high value. Bring it up. I fixed the thing of I need to see your vitamin D at above 60, and I don't care what I'm going to do to make it happen. And we try to bring it up to 60, 70, 80. Here's what happens most often. Most often that executive or that inpatient or that individual will test his antibodies. We pick up people at antibody testing every month or every 2 months. And their antibodies come positive, and some of them come very high antibodies, but their vitamin D is equally high. So, it's all good at the end. So people don't get sick, they don't get COVID. And again, my belief is once you've had COVID, I'm going to make a projection. I don't think we're going to get COVID again. So, yeah.
Darrell, you can rename yourself to Mubin, and I should start calling myself Darrell, because these are the messages that I've been giving as well, that once it's out, it's out. So protect yourself now, keep yourself safe now. It's going to go away. So thank you very much. I have a couple of more questions that are important here. One is Maya Menon says, is it okay to take Covaxin or Covishield as second dose after taking Pfizer? So she traveled to India. She's there. She had taken Pfizer. Now she's there for 3 months. Should she take other vaccines?
Maya, it's a great question. I would just do the Covishield all over again. Or if you want, talk to me and I'll protect you with other things like vitamin D and colchicine and all, and give you a whole plan. You can do the Covishield. Just be careful when you go to the vaccination center as to not to pick up the COVID infection in and around the vaccination center. What we are seeing is that the many asymptomatic patients, acute COVID patients, who are in the pre-symptomatic phase, who go in for the vaccination without having the symptoms, they end up breathing viruses out to other people. And some people who would go in for the vaccination come back to me day 7 with actually frank COVID. So be careful of that, Maya. Okay? I'm in Mumbai. If you're in India, give me a call sometime. Yeah, no problem.
A doctor is speaking. Excellent. So Dr. Amir Hashmi says dexamethasone dosage, and he had asked another question for the number of days. So would you like to tell us generally?
Dr. Amir, I use the low dose dexamethasone oral, preferably oral treatment protocol. Okay, so I use 1 milligram dexamethasone TID, morning, afternoon, night, initially for 5 days, and then taper it down to almost 0 over the next 10 days. So I go a full 15 days, but it's usually the first 5 days. I've not tried 7 days or 10 days. I seem to have had good success with the 5 days that 1 milligram TID. Now, when I get acute patients, when I get patients who are clotting, when I get patients who are unstable, somebody whose oxygen saturation is 60, 66, 79, 81, 85, I will go on with 4 milligrams of dexamethasone IM injection one time, and then do it BD for 3 days before I go to oral. So I will change based on the patient situation. Okay, and again, you're going to continue or discontinue your line of treatment or change your treatment based again on the oximeter reading improvement. If they get to 93, 94, 95, we're done. Then it's a recovery. If I can bring somebody from 65, 60, 66, 79 to 94 or 93 or 91, then I'll wait 3 days before I get the next point. Remember, when you have these acute patients, the gain, even if you get a 1 point gain every 2 days or every 3 days, I'm happy with it. I have a saying, I have a mantra. I have 2 mantras. I'll talk about my second one a little later. The first mantra is, perfection is the evil of good. I want a good result. As a clinician, I want a good result. I do not want a perfect result. So I'm willing to take trade off improvement to above 95 and say, I'm okay with 93 for now. Over time, over 2 weeks or 4 weeks, it'll go back to 95 or 96. And I've had people go back all the way to 98 within the 30 days. So these things happen. You just have to have patience, treat them the way you treat them. The other mantra I have is treat first, test later. Don't wait for test results. Okay, the minute, use your clinical skills, your clinical judgment. That's what I use. You've got COVID, sir. You're going to start treatment right now, and I don't care what your things are. It's based usually on your symptoms. It's based on your oximeter reading, based on your temperature. So whatever stage they come to me, it's treat first, test later. Okay.
Excellent. Thank you. Few more questions. I know that we are coming to 1.5 hours. Arpan Agarwal says, can we start 10 milligram rivaroxaban on day 1 or wait till D-dimer report in high-risk patients? Thanks to both.
Actually, you can use whatever anti-clotting drug you want on day 1. The earlier you use, the better it is. And don't wait for your D-dimer report. And again, the D-dimer report is more a lagging indicator. It's not a leading indicator. But the CRP is a better leading indicator. To me, I would rather go with a CRP than go with a D-dimer. A D-dimer to me is like yesterday's story. What happened yesterday or day before yesterday is telling me today. It's already clotted. I want to know what's happening today, which is the CRP, which is more important. So for me, I put much less importance on the D-dimer. I actually don't order the D-dimer now. I use my clinical judgment and go with the treatment. And of course, I have standard protocols now for like the 3-drug regimen. You can, whatever anti-clotting drug you use, you're comfortable with, use that. But start day 1. Don't wait till day 5 or 7. Okay.
Got it. Thank you. William Goff says, Dr. DeMello, the Indian variant is claimed to be more contagious than previous versions, but do you feel this new Indian variant is also more lethal than the previous versions?
William Goff, Bill, thank you for that question. Great question. Let me make this very clear. The Indian variant, the new variant that we've had, we've had multiple variants. There are probably 100 more variants around. I think the new variants are very transmissible. I've had families, 16 members of 2 families have got sick at the same time. So it's difficult when families get together, they're all going to get sick because of the transmissibility. Okay. However, it's less virulent. Okay? Because it's less virulent, you're not going to get the symptoms you got with the first variant. If you don't have those symptoms and people are still stuck in their head with fever being the symptom, and I've had even doctors tell me, we had malaise on, 10 days ago or 9 days ago. Yes, sir, that's a symptom. Plain malaise, lethargy, body ache, headache, something where you say, I worked too hard today, let me take a paracetamol, go to sleep, release my body pain, go to sleep. That is your day 1 of your symptoms. You got to get down to that level. The problem we are having with the less virulent virus, because of the less symptoms, patients are sitting on their symptoms. They're trying to self-treat, self-medicate. So they're treating themselves with paracetamol for 1, 2, 3 days. Then they go into the family doctor who says, oh, let us wait and see. Let's take these medicine for 2 days or 3 days. By the time they actually get a diagnosis, it's day 7. By the time they actually get to hospital or get to me, it's day 9, day 8 or 9. Their CT scan severity score can be 18 by that time. So delays is what's killing people. It's not the disease. The disease is a 14-day disease. So day 1 to 14, it still remains the same. The parts of the disease remain the same. It's just the virulence being less virulent means less symptom, means the patient is not being shaken up and saying, you got something wrong with you. And it's sneaking in on them before they know it. I'm giving the example. Last night I had somebody, or was it the night before? Night before I had somebody who messaged me on a WhatsApp message, the CT scan report of 14 by 25. And the minute I read it, I'm like, I'm coming to your home or you're coming to my home. So for me to come to your home, it's 1 hour drive. It's easier you come to me, I'll treat you, you go home. Then I don't waste 3 hours. So he came, he got treated. Today, his SpO2 is 98. Mind you, on that day, his SpO2 was 95, 96. He could have clotted off. I started my enoxaparin on the spot the minute he came to me before I did anything else. So these are things you have to do as a clinician. You have to make sure your patient is reversed or stable, first stabilized, then reverse. I like to see my V-shaped recoveries. I get plenty of V-shaped recoveries. It's just fascinating to see the type of V-shaped recoveries I get. Okay.
Awesome. Thank you very much. So, Gorilla, you were actually in the middle of answering his question and when the network went down. So, Dr. Mobeen, can you ask Demelo to answer my question about how to treat lung issues fully? The bad connection stopped. So, lung, how do we clear the lung?
Okay, let's talk about day 1 to 14, and we'll talk about later. Okay, day 1 to 14, if you got clots in the lung, use enoxaparin, use colchicine to actually treat the lung issue. Try to reduce the amount of clots in the lung in the first 14 days. Okay, so yeah, you'll go. My standard practice for enoxaparin, which is Lovenox in the US, is to use 60 milligrams BD twice a day, morning and night, for 5 days. And then I do once a day for 10 days. I could do 7 days. I could do 15 days, depending on the load or depending on the severity score. I decide, am I going 15 days? Am I going 10 days? Am I going 5 days, 7 days, or am I going 21 days? So that's the first part. Now, when I get to the second part, which will be usually in month 2, so between 31 and 60, I will then make a decision based again on a CT scan score. And depending on the score is 12, 10, 12, 14, 15. I will go in straight away with enoxaparin and colchicine and give them for again, 1 a day, 60 milligrams, 1 a day for 10 days, 15 days at the most. You can get damn good results with that. So let's just, so that's the way I treat. Now, are there other ways to treat? I'm sure there must be, but I've had great success with what I do, and I don't see any need for changing those treatment methods for now.
Makes sense. Makes sense. Thank you very much. One last question. So Dr. Sumit Kasare says, when do you advise CRP and CBC? Day 5 or at the start and then repeat it later?
I actually don't do any blood tests in the start. If I do a blood test or a CT scan, CRP, CBC, it'll be day 6, 7, or 8 when somebody is unstable. His oximeter reading is kind of bouncing between 93 and 96. And sometimes you can have that. You can have the oximeter oxygen saturation ratio showing at 93 when they're exercising or they're walking, and 96 when they're lying down or they're sitting on the bed. So when you're seeing that bouncing, be aware that clotting is occurring. So at that time, you can do a CRP, you can do a CBC. Doing a CRP, here, I'm going to give you a tip right up front here. And this is a tip for everybody in the world, okay? If your CRP number is more than 30, go on with a steroid. Bang the patient, hit the patient really hard with steroids. You will get instant success. You will get really dramatic success. I go on with dexamethasone, okay? I get great success if the CRP number is above 30. Below 30, however much steroids you may hammer them with, you're not going to get the success you get with something. If you see a CRP number at 140, at 170 or 89 or 79, bang them with steroids. They will recover over the next day or two. Of course, use enoxaparin, also use your colchicine or your anti-inflammatory, whichever one you're using. You'll see good success. This is again an observation I've had when I see a CRP number of more than 30, had very good success, versus less than 30, I don't have that much of success. Okay.
Got it. So Darrell, thank you very much. This was so fascinating that I did not want to just do the interview. I wanted to just hear you. So thank you very much for this great service that you're doing and then sharing. I am sure, as you saw, there were so many doctors here as well. People would pick it up, they would use this, they would serve, they would save people. This all credit goes to you and your work. Thank you very much for being here.
Thank you, Dr. Mobeen. It's been a delight being here with you and the cool beans. And I hope and pray that we can come back together again and share some more stories. We can talk different aspects of COVID sometime in the future.
Absolutely. So you are a cool bean now as well. We are actually planning a 10 to 20 hours long question answer session. So if you would like to join in the middle of that session somewhere next week, I would love to have you with us for an hour or so.
Sure. Absolutely, sir.
So thank you very much once again for your time. Thank you very much from the cool beans as well. As you can see, there are lots of thank yous. And this is just, you are a very popular doctor at this time, and thank you for your clinical work. I'm just overwhelmed. So thank you. And thank you very much, cool beans as well. I would see you this evening.
It's been a fascinating experience. That's all I can say. It's been an out of the world experience I've had treating COVID patients in India. It's just out of the world.
Yeah. Thank you. Thank you.
Thank you, sir.